Well, students, and welcome to today's session on the uveal tract. A very underrated topic. Not many students will really focus on this anatomy, but it's a very important anatomy to understand so that you can understand the angle of anterior chamber as well. So I strongly recommend you to watch this video first before moving on to the angle of anterior chamber anatomy. So it will give you more comprehension or more orientation when you're going to read or watch that lecture. So in this, we'll start with the embryology of the uveal tract. And we have discussed already in the angle of anterior chamber as well, to review, iris, ciliary body and choroid together constitute the uveal tract, ICC. Remember that. The iris and ciliary body, both of them possess epithelium, both of them possess muscles, both of them possess stroma. The iris and ciliary body epithelium are going to be derived from the neuroectoderm. Okay, neuroectoderm. The stroma of iris and ciliary body is going to be derived from the neural crest cells. But when it comes to the muscles, there is a division. The muscle of the iris, dilator pupillae and sphincter pupillae, are going to be derived from the neuroectoderm, whereas the ciliary muscle is going to be derived from the neural crest cell. Choroid is going to get developed from the neural crest cell as well. So as you can see, neural crest cell is going to be the stroma, the ciliary muscle and the choroid. This is a very important picture, so please focus on this. This is going to be the optic cup, which is going to form the future retina. The optic cup has two layers, the outer part of the optic cup or the outer cup, the inner part of the optic cup also called as the inner cup. The outer cup is going to continue or form as the retinal pigmentary epithelium of the retina, which then progresses to form the pigmented ciliary epithelium of the ciliary body, which then continues as the anterior myoepithelium of the iris. On the contrary, the inner cup is going to form the neurosensory retina, which then progresses to form the non-pigmented ciliary epithelium, which then forms the posterior pigmented epithelium. So here it is non-pigmented in ciliary body, in iris it is pigmented. So this is going to be a very important picture. So remember, it is going to be a bi-layered epithelium. You have an anterior epithelium, you have a posterior epithelium on the ciliary body. So the inner cup is going to progress as the posterior non-pigmented epithelium of the ciliary body, which then continues as the posterior pigmented epithelium of the iris. As you can see in this picture, this blue color is going to be the posterior non-pigmented epithelium, which then continues as the posterior pigmented epithelium of the iris. Whereas the outer cup, which forms the anterior pigmented epithelium of the ciliary body, as you can see in this picture, this red color, which continues as the anterior myoepithelium of the iris. So please remember, this is a very confusing anatomy, but it is important to know the details as well. So moving on to the anatomy proper. As I just discussed, uveal tract consists of iris, ciliary body and choroid. It is going to be the middle, or it's going to be the typical vascular tunic or the coat of the eyeball. Cornea layer is going to be the protective layer. Retina is going to be the nervous layer. On the contrary, uveal tract is going to be this middle layer, which is going to be the so-called vascular layer, because it is a richly vascularized structure. That is why in human body, if there's going to be any systemic conditions like tuberculosis, sarcoidosis, both infections as well as autoimmune pathologies, they can run in the blood, be it infectious organisms or be it the autoimmune complexes. They can run in the body and they can manifest in the eye as a uveal pathology or uveitis. And that is why it is important to understand the anatomy of the uveal tract, because only based on the anatomy we are classifying uveitis as given by standardization of uveitis nomenclature. A very important Sun classification of uveitis. To be more specific, the Sun's anatomical classification of uveitis is based upon the anatomy of the uveal tract. That is why you have to consider it as very important. The details of this will be dealt by the uveitis specialist, but for now just understand that you have an anterior uveitis, intermediate uveitis, posterior uveitis and panuveitis. When I mean anterior uveitis, the primary site of inflammation is going to be the anterior chamber. When I mean intermediate uveitis, the primary site of inflammation is going to be the vitreous. And when I mean the posterior uveitis, it's going to be retina and choroid going to be the primary sites of inflammation. Pan means everything. So all the both anterior chamber, vitreous, retina, choroidal, all involved is called as pan-uveitis. So depending upon the anatomical classification in uveitis, the systemic manifestations will differ. Also, not just that, the ocular symptoms also will be differing. For example, anteruveitis is going to be anterior chamber. So you will see more of AC reaction, see cells and flare, you will see ciliary congestion. On the contrary, in intermediate uveitis, since vitreous is going to be the primary site of involvement, the patient will experience floaters rather than congestion. So three main attachments of uvea is going to be scleral spur, the exit of vortex veins, and the optic nerve. Now this attachment is very, very important because when there's going to be a choroidal detachment, what happens? You can see the extension of the detachment crosses beyond the ora serrata. So this is called the kissing choroids. Kissing choroids, as you see, as you expect in a choroidal detachment. On the contrary, a retinal detachment will not extend or will not cross the ora serrata. So just because of this peculiar attachment of the uveal tract, to be more specific, the choroid, as you can see at the scleral spur. So till here it is attached. That's why when there's a CD, you expect a detachment like this. So far, we just finished the basic orientation towards uveal tract. Moving on to the more specifics, we'll discuss about iris, ciliary body, and choroid in detail, starting with iris. As far as iris is concerned, we'll discuss about the gross anatomy and the microscopic anatomy. So as far as the gross anatomy is concerned, iris is going to be divided into topographically into two regions, the outer ciliary region and the inner pupillary region. The outer ciliary region, the inner pupillary region. At the border of the pupil, you have this pupillary ruff or pupillary frill. So three important components: ciliary region, pupillary region. At the pupillary end, it's going to be pupillary ruff or pupillary frill. I've just taken a cross section of this and exposed in the next slide. As you can see, this is going to be the pupillary ruff. And here you have two important crypts, the peripheral crypts and the middle crypts, or the fuchs crypts, or the central crypts. So remember, two crypts on the anterior end, the peripheral crypts at the periphery and the central crypts just at the collarate region. So what is collarate? Collarate is going to be that region or that area which divides the iris into the pupillary zone and the ciliary zone, exactly at this area. This part is called as the collarate, which is a division between the ciliary portion, ciliary region, and the pupillary region. This is going to be the anterior view. The posterior view has important structures, two structures, radial contraction furrows and structural folds of Schwalbe's. Radial contraction furrows and structural folds of Schwalbe. Just remember these two. The importance of pupillary ruff or the pupillary frill is that it is very much seen in normal patients, and sometimes you can see absence or loss of pupillary ruff in very important pathological conditions such as pseudo-exfoliation glaucoma, pigment dispersion syndrome, chronic ankylosing, chronic uveitis. You can experience loss of pupillary ruff. That's why it's always important to look at the pupil ruff in these patients. In this picture shows the typical pseudo-exfoliation where it's going to be a loss of pupillary ruff. We discussed about the importance of iris root or the periphery of the iris in the angle of anterior chamber. Just to connect, the periphery of iris also has a root of iris, and here is going to be the iris root, which is attaching to the ciliary body band. And that is why iris root is going to be one of the important 5 structures in the angle of anterior chamber. So starting from anterior to posterior, you have the Schwalbe's line, trabecular meshwork along which lens cannot, scleral spur, ciliary body band, and lastly, or the posterior most part of the angle of anterior chamber is going to be the peripheral iris or the root of iris. Very important. So the microscopic anatomy of the iris. Iris on cross section can be the following structures. You have the anterior border layer, the stroma along with the sphincter pupillae muscle, anterior myoepithelium, and the posterior pigmented epithelium. So both these things are going to be the typical bi-layered epithelium. The bi-layered epithelium of the iris and ciliary body. So it's going to be only for iris. So you can see the anterior border layer, stroma, the anterior myoepithelium, which means it has a muscle. What is the muscle? Dilator pupillae, and PPE or posterior pigmented epithelium. So this is a diagrammatic representation of the same. So it's going to be the iris, and this part is going to be the anterior part, this is the posterior part. Okay. So it's the anterior border layer, it's going to be the stroma, which has the dilator pupillae muscle. Very, very important. You can see the stroma, dilator pupillae muscle is on the AME or anterior myoepithelium. So myo means muscle. So what is that muscle which is a component of stroma? S for S, sphincter pupillae just at the end of the iris margin. And you have the PPE or the posterior pigmented epithelium. We'll talk about each one of them one by one. Anterior border layer is going to be, which means that there is no epithelium on the anterior part of the iris. So it's an anterior epithelium-less layer. Nothing but a condensation of stroma or condensation of melanin. That is why in any pathologies where there is going to be a loss of melanin, the patients will be having blue-colored iris or non-pigmented or hypochromic iris as a consequence of loss of melanin, especially in conditions like albinism. albinism. Okay? And the melanin content will vary in different pathologies accordingly. So it's going to be the anterior border layer, which we finished now. Moving on to the iris stroma. Technically speaking, the stroma consists of two muscles, sphincter pupillae and dilator pupillae. Some authorities consider dilator pupillae as a part of the anterior myoepithelium, but still, if someone asks the two muscles in the iris, always are the sphincter pupillae and dilator pupillae. The two structures are going to be nerves and vessels. So you have nerves, you have vessels there. The two types of cells are going to be the pigmented cells and the non-pigmented cells. The pigmented cells are going to be melanocytes and the clump cells. The non-pigmented cells are going to be fibroblasts, lymphocytes, macrophages, and mast cells. So just remember this rule of two: two muscles, two structures, and two types of cells: pigmented cells and the non-pigmented cells. So finished about the iris stroma. We finished about the anterior border layer. Moving on to the epithelium. The epithelium is going to be a bi-layered epithelium. You have an anterior myoepithelium and a posterior pigmented epithelium. Please remember, it's going to be a non-pigmented epithelium on the posterior aspect for ciliary body. As it comes to the iris, what happens? The iris is going to attain melanin. It's going to be melanogenesis, as a result of which the pigmented epithelium happens. In other words, the posterior pigmented epithelium is occurring from a non-pigmented epithelium of the ciliary body. So during embryology, what happens is going to be uptake of melanin. That is why, again, in fact, in case like albinism, the patients will not be having pigmentation in the epithelium, leading on to a hypochromic or albinic iris. Moving on to the anterior myoepithelium. So it's a very, very important diagram. So please reproduce this diagram in your exams as well. This is going to be the anterior border layer, the stroma. As you can see, the dilator pupillae muscle is going to be attached to the anterior myopithelium. In other words, the anterior myopithelium is going to have two portions. You have a basal portion and you have an apical portion. Basal portion, apical portion. The basal portion is going to be associated with the dilator pupillae muscle, whereas on the contrary, the apical portion is going to be associated with the posterior pigment epithelium. One important point what we discuss in textbook is going to be the typical apex to apex configuration of these. Which means the apical portion of the anterior myoepithelium is going to face the apical portion of the posterior pigmented epithelium. So both the anterior and the posterior, both the apices are going to face each other. This is called the apex to apex configuration, which is very important from an embryological point of view. So posterior pigmented epithelium is going to be the posterior most structure of the microscopic anatomy of the iris. So here, one important clinical point is that if this PPE is going to be extended to the anterior part, in other words, it's going to be the PPE, posterior pigmented epithelium. If it's going to extend anteriorly, if it's going to extend all the way towards the anterior surface of the iris, that is what you call as the ectropion uvea. Very important condition. Ectropion uvea is very often a classic feature of neovascularization of iris, which happens in neovascular glaucoma. Very important point. It can be congenital also. So it can be both physiological as well as pathological. But presence of ectropion uvea should be an indicator of the fact that because of the new vessels being formed in the iris, because of the fibrovascular pull, as a result of which what happens, this PPE is going to be pulled up by the new vessels, thereby leading on to ectropion uvea. Very, very important structure. One more important clinical feature is that because of the presence of the posterior pigmented epithelium of the iris, in a condition such as a pigment dispersion syndrome, where there is a posterior bowing of the iris, the posterior bowing of the iris, as a result of which what happens, is going to rub against the zonules. There's going to be release of pigments from the PPE, from the posterior pigmented epithelium. As a result of which these pigments are going to get dispersed or distributed to various parts of the iris, such as trabecular meshwork, anterior chamber, and cornea. In cornea, it is called as a Krukenberg's spindle. Krukenberg spindle. So we're discussing all these things in separate glaucoma lectures. But for now, just understand that this is going to be the pathogenesis of pigment dispersion syndrome. So why you have a pigment dispersion? From where the pigment is going to be dispersed? From the posterior pigmented epithelium of the iris. Moving on to the muscles of iris. Muscles of iris is going to be two: the dilator pupillae and the sphincter pupillae. And these two muscles are going to determine or rule the pupillary reflexes. Pupillary reflex path is going to be a very, very important, frequently asked exam question, both in Viva, clinical, as well as theory part as well, because of its neuro-ophthalmologic significance. So I'm going to just discuss very short, very brief information about both dilator pupillae as well as sphincter pupillae. The details of the innervation and the reflex pathway will be dealt in the neuro-ophthalmology lectures by a neuro-ophthalmologist. So dilator pupillae is going to be extending from the iris root till the mid-sphincter level. So it's like here. You can see it's like this. This is going to be dilator pupillae, kind of at the periphery. Whereas sphincter pupillae is going to be at the pupillary border. It's going to be like this. So what happens? Dilator pupillae is going to be a radial smooth muscle. It's going to be like a radial smooth muscle. So when they're going to contract, they're going to dilate, stretch the pupil leading to dilatation or mydriasis. On the contrary, the sphincter pupillae is going to be like this, like a circular smooth muscle. So when they constrict like a sphincter, like an anal sphincter, they're going to constrict leading on to meiosis. So meiosis is the constriction of pupil, mydriasis is going to be the dilatation of pupil. Dilator pupillae is going to be by sympathetic innervation, whereas the sphincter pupillae is going to be from the parasympathetic innervation. So please don't forget, it's very, very basic, very important. That's why whenever we have any anxiety or any apprehension or some emotional rise, what happens? Our pupils going to get dilated because of sympathetic innervation, adrenaline rush in the body, causing to the pupils to dilate. On the contrary, a parasympathetic innervation, in case of very calm or very relaxed mode, what happens, or even when we sleep also, there's going to be more of a parasympathetic tone as a result of it going to be meiosis. Just in brief about the innervation of each muscle. So it's going to be a very important high yield topic. So please read from your relevant neuro lectures as well. Edinger-Westphal nucleus is going to be that nucleus which is going to give the third cranial nerve. The third cranial nerve is going to go and attach to the ciliary ganglion. From ciliary ganglion is going to be short ciliary nerves. The short ciliary nerve is going to supply the sphincter pupillae and the ciliary muscle. As a result of it is going to be meiosis and accommodation respectively. The clinical point here is going to be any aneurysm or any tumor compressing the third cranial nerve. What happens? That is going to cause a fixed dilated pupil, because that pupil muscles or those nerve fibers which are going to supply the sphincter pupillae are going to be at the peripheral part of the third cranial nerve. It's called third cranial nerve at the periphery part. So what happens when there's going to be a lesion, an aneurysm or a tumor compressing on those fibers supplying the pupil? What happens? There's going to be loss of meiosis. Okay, so it's going to be fixed dilated pupil. It's going to be accommodative paralysis. What you call as a pupil involving third cranial nerve, which is going to be a neuro-ophthalmic emergency. It's one of those very few emergencies in ophthalmology, but very, very important. Whenever you see a patient third cranial nerve palsy, the pupil involved, it's going to be fixed dilated pupil. Always order neuroimaging, order MRI brain with MRA. MR angiogram, so as to find any aneurysms are there or not. As far as the dilated pupil is concerned, I just told it's going to be the sympathetic supply. So it's going to be trigeminal ganglion, which has three nerves: ophthalmic nerve, maxillary nerve, and the mandibular nerve. The ophthalmic nerve is going to give a branch called nasociliary nerve, and from the nasociliary nerve is one more branch called the long ciliary nerve. The long ciliary nerve is going to get contributions from the sympathetic plexus, which is on the internal carotid artery, and that's going to supply to the dilated pupillary muscle. So because of sympathetic innervation, is going to be mydriasis. In an important pathology called Horner syndrome, there is going to be affection, or is going to be destruction of the sympathetic plexus. Sympathetic denervation is going to happen, as a result of which the patient will have meiosis. So in Horner's, is going to be meiosis. In third cranial nerve, palsy, is going to be a fixed dilated pupillar mydriasis. One important clinical point as far as iris is concerned is that posterior synechiae is very often seen in uveitis pathology. So why do you have this posterior synechiae? It's when the posterior epithelium along with the sphincter pupillae, they're going to be adherent on the ALC. The reason why you have small sluggish pupil in case of uveitis is because of this important concept. You have the posterior epithelium moving forwards, moving towards the ALC or anterior lens capsule. It's going to be the lens. This is the anterior lens capsule. So this posterior epithelium part, along with the sphincter pupillae, which is at the pupillary border, both of them are going to cause adherence to the ALC, leading to the typical posterior synechiae, what we see in uveitis. Very commonly asked question exam is going to be the iris vessels, or differences between the new vessels of the iris and going to be the normal vessels of the iris. So it's important to know the vascular anatomy of the iris. So we'll discuss about the blood supply of uveal tract in the next lecture. But for now, we just read only the relevant part as far as iris is concerned. See, this is going to be the iris. This is going to be the pupil. This part is going to be the collarette, and this part is going to be the peripheral root of the iris. Periphery of the iris. There are two important arterial circles: the major arterial circle and the minor arterial circle. The minor arterial circle is going to be at the collarette. So minor arterial circle is going to be at the collarette. So please don't forget this. Collarette, you have minor arterial circle. On the contrary, the major arterial circle is not on the iris. Just because the name is going to be on the iris, it is not going to be on the iris, but it's going to be the apex of the ciliary body. So very often students make a mistake at this point in their exams. Always remember, the minor arterial circle is going to be on the collarette. The major one is going to be not on the iris, but on the apex of the ciliary body. So still outside here is the major arterial circle, as you can see here. Okay. So a very frequently asked question is going to be the differences between the new vessels of the iris and the normal vessels on the iris. As you can see, this is going to be the scleral spur. This part. Okay. Any vessel crossing scleral spur is pathological. I'm going to discuss this in the angle of anterior chamber anatomy, but again, I'm going to re-emphasize this point. Any vessel crossing scleral spur is pathological. So a vessel crossing scleral spur is going to be a new vessel or a pathological vessel on the iris. And most often, the new vessel is going to be at the pupillary margin. So you can see the new vessel is going to be the pupillary margin at the periphery also, at time extending or crossing scleral spur. And the new vessels are going to be thin, arborizing, fenestrated vessels. They are like discontinuous, fenestrated, a lot of leaky junctions, no tight junctions, leaky borders. As a result of it, there's going to be poor blood aqueous barrier. That is why, in case of NVI, which is commonly seen in neovascular glaucoma, there's going to be release of proteins because of the poor junctions. As a result of it, there's going to be uveitis in case of, or anterior chamber reaction in case of neovascular glaucoma. And they can also leak fluorescent. And it's just made of only endothelial tubes, just a single layer of endothelial tubes, which one the new vessels of the iris. On the contrary, the normal vessels will not cross scleral spur, very important, and they are deep in stroma. They're more of radial vessels. They're deep in stroma. They're thin, radial, non-fenestrated, which means they provide intact blood aqueous barrier, which we'll deal with at the end of the lecture, and they will not leak any fluorescent. And as like any other normal vessel, the normal vessels of iris will have the three important structures: the tunica intima, tunica media, and the tunica adventitia. Moving on to the ciliary body. Ciliary body, again, like in iris, there's a rule of two. There are two functions of ciliary body. One's going to be the aqueous humor formation, or aqueous humor secretion, and accommodation. A very important physiology as far as seeing near objects is concerned. The two zones are going to be pars plana and pars plicata. And again, you're going to have two epithelium, just like iris, a bilayered epithelium. You have an anterior pigmented epithelium and the posterior non-pigmented epithelium. So non-pigmented in the ciliary body, pigmented in the iris. The two zones are going to be the pars plana. This is a pars plana, which means it's like a plane. Pars plica is going to be this plications or multiple undulations or folds can be noted. And those folds or undulations are called as ciliary processes, which are major sites of aqueous secretion. As you can see, it's going to be the ciliary body. This is the iris part. And you can see ciliary muscle here, very important structure. We'll discuss everything about it in detail. And note here is going to be the trabecular meshwork, this purple thing. So going to be the Schlemm's canal. So how does aqueous going to secrete? Aqueous going to come from here all the way to the pupil into the trabecular meshwork. The pars plana, very important clinically relevant area. That's why you have a pars plana vitrectomy. Very often we use the term or hear the term pars plana. This is going to be choroid. This is going to be the ciliary body, the pars plana. This is pars plicata. The ciliary processes. This is going to be iris. So the picture is clear. And this is retina. This is ending at the ora serrata region. So this pars plana is going to be a smooth and an avascular zone. Smooth zone, avascular zone. Most importantly, it is the safest point of entry into the eye for vitrectomy without having to damage the lens, without having to damage the retina. The safest entry is going to be pars plana. That is why this structure is of ultimate importance from a clinical perspective, from a surgical perspective. Safe area. So one important question for the last exam is going to be the intravitreal injection. So intravitreal injection means from where do you give intravitreal injections, and what is the distance from the limbus at which you give intravitreal injection. So it depends upon aphakia, pseudophakia, and phakia. So it depends upon the lens status. In aphakia, it is 3 mm from the limbus. Pseudophakia is going to be 3.5 mm from the limbus. Phakia is going to be 4 mm from the limbus. So most of you might be doing this, but you cannot really visualize this much. So I've drawn some diagrams here for you to understand. So it's going to be aphakia, no lens at all. So he can easily, or the surgeon or the ophthalmologist can easily enter at the nearer part of the limbus. So it's just 3 mm. On the contrary, it's going to be a PCIL, it's going to be pseudophakia. What happens? The doctor has to be careful. So 3.5 mm from the limbus. But you have to be very, very careful when you're going to give intravitreal injections to a patient who is having a lens. Okay, a phakic patient, where you should not cause any inadvertent ALC injury or a PC injury. So you should not give here. You should not give 3 mm. You should not give 3.5. You should get 4 mm for phakic. So remember, phakic 4 mm in phakic. So patient having lens. Pars plicatum, on the other hand, is going to be rich vascularized structure compared to the avascular pars plana. There are 70 radial folds, what we call the ciliary processes, hence the major site of aqueous production. So one important thing to consider is going to be the microscopic structure of ciliary body. Okay, so both the pars plana and the pars plicatum will consist of these structures: the supraciliary space, ciliary muscle, ciliary body stroma, and the bilayered ciliary epithelium. Okay, pigmented epithelium and the non-pigmented epithelium. Again, this is going to be the supraciliary space, the space between the ciliary body and the sclera. This is sclera, this is cornea. Okay, supraciliary space. Here is going to be the ciliary muscle and the ciliary body stroma within the body of the ciliary body, the actual core, and the bilayered epithelium here. Okay, so this is a very important, easy to reproduce structure in the exams as well. We'll take one by one. Supraciliary space is going to be the space between the sclera and ciliary body or choroid. Okay, so it's going to be a very important outlet for the uveoscleral outflow of aqueous humor, which we discussed in the angle of anterior chamber. A very important space where you can deliver drugs, and also not just that, you can place microstents in minimally invasive glaucoma surgeries as well in the supraciliary space. These are some of the important clinical applications of supraciliary space. Ciliary muscle is going to be a very important structure. It consists of 3 important components. Please don't forget it, very important. The outer longitudinal, the middle radial, and the innermost circular. Outer longitudinal, middle radial, inner circular. The outer longitudinal is called as the brux muscle, which is attaching to the scleral spur. Okay, this is going to be the scleral spur at this area. This part of the sclera. So this longitudinal is going to get attached to the scleral spur. What happens on contraction? You're going to pull the scleral spur, opens a trabecular meshwork leading on to aqueous drainage. So very important is this. So the trabecular outflow is going to be facilitated by the action of the longitudinal part of the ciliary muscle. On the contrary, the inner circular muscle is going to help in the accommodation. So 2 important functions of ciliary muscle are going to be trabecular outflow. Second is going to be accommodation. So as you all know, what is accommodation? Accommodation is a process where it's going to be ciliary muscle, zonules, lens. So what happens? There's going to be contraction of the ciliary muscle. What muscle? It's going to be the circular muscle. The circular muscle, the inner circular muscle, when they contract, there's going to be a ciliary in diameter is going to get reduced. There's going to be slackening or relaxation of the zonules, as the result of which the lens will attain more spherical configuration, leading on to accommodation. The details of accommodation I've dealt in the lens chapter, so please watch that. Moving on to ciliary stroma. Stroma means it has connective tissue, blood vessels, and nerves. A very important point to consider is that it has this fibrovascular matrix. Fibrovascular matrix, which is going to weave through the ciliary muscle. So what is the fibrovascular matrix? The connective tissue which is going to weave through the ciliary muscle. And this connective tissue is a very important site of a very important anti-glaucoma medication. Is going to be prostaglandin analog. Prostaglandin analog. So what happens is that this is going to be ciliary muscle. And here you have these kind of connective tissues going to happen. So your latinoprost or prostaglandin analog is going to act on that. It's going to, with the help of matrix metalloproteinases, it's going to cause a degradation of the extracellular matrix. They'll be facilitating uveoscleral outflow. So speaking of which, uveoscleral pathway of aqueous is going to be the unconventional pathway of aqueous outflow, aqueous drainage, which goes through these following parts: ciliary body band for the ciliary stroma, ciliary muscle, and through the fibrovascular matrix, supraciliary space with sclera. So coming back, so from here is going to be secretion of aqueous. It's going to go to the posterior chamber, cross the pupil, go to the anterior chamber, and from there it's going to enter the ciliary body stroma, ciliary muscle, supraciliary space, the sclera. This is going to be the exact pathway of the uveoscleral outflow, the unconventional outflow of aqueous humor drainage. Very important. We finished about the ciliary body itself. We discussed about ciliary muscle also. Moving on to ciliary epithelium, the last structure, just bi-layered. Now, why this is important is because you should know the orientation to understand the aqueous secretion. So please know that this is going to be the posterior non-pigmented epithelium, this blue color. This blue color is going to face the posterior chamber. So the posterior non-pigmented epithelium is going to face the posterior chamber. Makes sense. Now what happens? Aqueous is going to get drained into the posterior chamber. So the ciliary process is going to be the sites of aqueous production. So as already discussed in the lecture on angle of anterior chamber. Okay, ciliary process is going to be like a finger, where there's going to be a central vascular core which is going to secrete aqueous. So this is going to be the flow or direction of the aqueous outflow from here through the anterior pigmented epithelium to the posterior non-pigmented epithelium to the posterior chamber. So I've drawn this in a ulta way. This is going to be the capillaries, the same capillaries I've drawn here, and this pink color I've drawn here. This pink is going to be the anterior pigmented epithelium, and this blue color I've drawn here, which is going to be the non-pigmented epithelium. So what happens here is that what is going to be the flow or the way through which the aqueous is going to secrete it. So it's going to be from the fenestrated capillaries, from there to the pigmented epithelium, from there to the non-pigmented epithelium, and from there finally to the posterior chamber. So this is going to be the secretion of the aqueous. I've dealt everything in detail in the angle lecture, so please watch that, have a complete understanding. One important clinical application of uveal tract is going to be the presence of blood-ocular barrier. So what is blood-ocular barrier? To be more specific, what is blood-aqueous barrier? Another very commonly asked exam question, very commonly asked viva question. The blood-ocular barrier is going to be divided into blood-aqueous barrier and a blood-retinal barrier, which means there exists a barrier where the blood and the aqueous should not mix. Again, where blood and retina should not mix. So blood-aqueous barrier is essentially formed by the tight junctions of, please note this, very important, tight junctions of the non-pigmented epithelium of ciliary body. So remember this part? The non-pigmented epithelium, all these tight junctions are going to form the blood-aqueous barrier, a very important component of blood-aqueous barrier. Iris vessels. Remember we discussed about the difference between the new vessel and the iris vessel. Iris vessels are these tight junctions. So the iris vessels are going to be this non-fenestrated endothelium. So those tight integral walls are going to prevent the leakage. Third is going to be the inner wall of Schlemm's canal. So you may remember non-pigmented epithelium of ciliary body. You may remember iris vessels, but you might forget the Schlemm's canal's inner wall. So please don't forget this. So 3 important structures which are going to form the blood-aqueous barrier. Okay? As far as blood-retinal barrier is concerned, just know we'll discuss everything in detail in the retinal anatomy. For now, just know there is going to be an inner blood-retinal barrier. You have an outer blood-retinal barrier. The inner barrier is going to be formed by the tight junction of retinal capillaries. So with iris vessels, the retinal capillaries are going to form these tight junctions, which is going to form the inner blood-retinal barrier. On the contrary, the outer BRB is going to be formed by the tight junctions of RPE, retinal pigmentary epithelium. So it's a very important, favorite, frequently asked question in viva exams. To review, The blood aqueous barrier is going to be formed by the non-pigmented ciliary epithelium, iris vessels, and the inner wall endothelium of Schlemm's canal. Why I'm always repeating this? What is the importance of blood aqueous barrier? Breach of blood aqueous barrier is going to be the fundamental pathophysiology in uveitis. Very common last exam question. The strong principle is this. So the function of blood aqueous barrier is going to be to maintain the clarity of aqueous. So aqueous is going to be like clear. Only if the aqueous is clear, only if the lens is clear, only if the cornea is clear, the light can pass through. So what if the aqueous is going to be not clear? Which means, what if the blood aqueous barrier is going to be breached? We'll discuss that. The important function of blood aqueous barrier is that it should maintain a protein-free aqueous. So one of the reasons why you have a loss of clarity of aqueous is going to be because of protein-rich aqueous. There's going to be too much proteins inside. As a consequence of the breach of blood aqueous barrier is going to be presence of cells and fat. We'll discuss it in a moment. And one more function of blood aqueous barrier is that it should maintain high levels of ascorbate. Just know that. But the two important functions are going to be to maintain the clarity of aqueous and to make the aqueous essentially protein-free. There are many conditions which can cause a break or a breach of blood aqueous barrier. So one important thing what we saw was uveitis. So any intraocular inflammation such as uveitis can cause a break in the blood aqueous barrier. Apart from that, a trauma can be either a mechanical trauma, surgical trauma, or chemical trauma can cause again breach or breakage of this blood aqueous barrier. Ischemia, ocular ischemic syndrome in case of neovascular glaucoma. Usage of drugs, very important, commonly asked exam question. They will ask name two drugs which can increase the intraocular inflammation. Prostaglandin analog and pilocarpine. Remember two P's which can cause uveitis or which can cause AC reactions going to be prostaglandin analogs and pilocarpine. So what happens when this blood aqueous barrier gets broken? So it's going to be the vessel. So when this BAB gets breached, what happens is going to be release of two important structures. There's going to be release of cells, RBCs, WBCs, etc. Release of protein into the aqueous. When there's release of the white blood cells in the aqueous, that is what you call as AC cells, anterior chamber cells. When there's going to be a release of proteins into the aqueous, that is what you call as AC flare. AC flare. So two important clinical signs to be noted when a patient will have uveitis is going to be AC cells and AC flare. So I want to end with this clinical application. Flare means protein leak. Cells means inflammatory cells in the optically clear aqueous humor, which is supposed to be clear. But because of any pathology, the patient can have a very dirty aqueous mixed with cells as well as protein. So presence of cells is going to be the typical AC cells, and presence of the protein is going to be the AC flare. Okay, so very important exam question. So exam they'll ask you, how will you grade AC flare? How will you grade AC cells? So this is something like the typical physics phenomenon what you have read sometime back, the Tyndall effect and the Brownian movement. So it's like when you open the window in the early morning, you have the sunlight coming and you can see a lot of dust particles in the sunlight. So those dust particles are going to be the AC cells. That sunlight is going to be the AC flare. So with this basic clinical applications, I want to end this lecture. So complete detailed overview of the clinical features, signs, symptoms will be dealt by the uveitis specialists. So for now, we finish with the uveal tract, part 1. In part 2, we discuss about the anatomy of choroid and the blood supply of uveal tract, and we'll end with a very important high yield pathology of uveitis. Thank you.
Mệt, có giờ này xì chết quá. Toàn gặp mấy cái đứa gì đâu.